Madam, madam, is it audible to you?
Yes.
Madam, is it audible to you? We welcome
Yes.
you, ma'am. Just you.
Thank you so much.
Thank
Thank
you.
you
Just
very much.
our president will give a brief introduction about you, ma'am.
Thank you.
Good morning. Dr. Revathi Raj, she is DCH, MRCP, FRCP, Pathology, UK. Trained in the UK in pediatrics and hematology, oncology, and bone marrow transplantation till 2001. Consultant in Apollo Hospital, Chennai, India, since March 2002. Providing comprehensive and holistic care for children with cancer and hematological disorders. Areas of interest: HSCT for thalassemia and PID, childhood leukemia. Novel therapies like cord blood and hepatoidentical HSCT. We welcome you, madam.
Thank you very much, sir. Thank you for the kind invitation and the introduction. Can I share my screen, please?
Yeah, please share.
So, good morning, Vanakkam, and I wish to begin by thanking the Tamil Nadu and Puducherry Pediatric Surgical Group for this invitation. When I first got the call from Dr. Sripathi and Dr. Pavai, I was very surprised because all these 20 years here, my forte had been with the hematological condition, and this is the first time ever that I'm addressing a group on solid tumors. Neuroblastoma is very unique, and I want to really thank all of you from the bottom of my heart for this honor and privilege and the invitation. I have learned a lot whilst preparing for these slides and over the years. And thank you to the entire group for this opportunity. So I want to begin by placing this tribute to Dr. Yusuf and his family members who have done this really rare, unique thing. This is from Avayar's saying, Ariyadu Edu. And she goes on to say that Jnanam, Kalvi, Danam, and Ellame Seyyardu Aridu. And we've had this great surgeon whom none of us, I haven't seen myself, but I read the oration and who he was. And I'm really glad that his son wanted to show respect to his father by honoring him through knowledge, to have this oration placed and to invite people from other specialities who would enrich the knowledge for pediatric surgical group. And I wish the family all the very best in their life and in their journey. And I hope I would do justice to this oration. So a salute to Dr. Yusuf. So why did I choose neuroblastoma? I feel in the cancers that we see, it's the most enigmatic disease. If you have early diagnosis, the cure rates are very high. If you have advanced diagnosis, it's very, very poor, the outlook. And this is one tumor where infants do better. And suddenly, out of the blue, the tumor spontaneously regress. So it's a cancer yesterday, and today they're cured with no treatment. We have great understanding of the biology of the disease now, and hence, as a result, targeted therapy. So I thought this would be a good platform to share all the knowledge that has been gained over the last few decades on neuroblastoma. Although it forms only about 6% of the childhood cancers that we treat. but there's been a huge difference in the outcomes over the last couple of decades. And this has been my learning curve. So much of the biology matters, and every decade we have new information on the disease biology, and it has taught us to adapt to current scientific knowledge. When I first started working in India in 2002, I thought neuroblastoma stage 4, I'm never going to offer treatment. And here I am 20 years later doing an oration on advances in neuroblastoma, because there's been so much insight into how we can do better. It's taught us how to work as a team, be respectful of the role of every member of the team, be it surgeons, radiation oncologists, nuclear medicine people, pathologists, how much information we've gained. And the journey of neuroblastoma has helped me come into contact with an amazing group of physicians, surgeons, whom I'm very, very happy to call as friends today. And this is one condition where we've learned late effects prevention start today. We shouldn't aim just for cure, but also for intact survival. So what we can do. And it has also taught me a lot of humility, because when we know we have to stop, we have to stop, because as a pediatric oncologist, our main thing is to do more, more, more. If what can we do more? What can we do more? But this is taught us humility to learn when to stop. So this is my learning curve with neuroblastoma. So during the course of the next half an hour, I want to leave you all with 10 pearls of what I have gathered over the years on neuroblastoma, and I've called it the 10 commandments. So this is one disease we treat based on risk stratification. So you have children with low risk, intermediate risk, and high risk. And low risk, they have only surgery. Intermediate risk, they have surgery plus chemotherapy in moderate doses. And high risk, we throw everything at them. They have surgery, they have chemotherapy, they have radiotherapy, they have autologous transplants, differentiating agents. And then we have the stage 4S, which is a unique group, which is of infants. So what are the things that we have learned over time about neuroblastoma? The location matters. And for each location, the genes that are involved in resulting in the neuroblastoma are different. So if they are from the adrenal gland, retroperitoneum, thoracic, pelvic, and neck, adrenal fares the worst. All the others do better, although they form about half the population of neuroblastoma. Age matters. So if you see a small baby who's presented with neuroblastoma, initially metastatic disease riddled with neuroblastoma, over time, the disease can differentiate, become ganglioneuroblastoma, ganglioneuroma, and finally resolve. So this is a unique situation with infants, and the biology is different, and the age cutoff is 18 months. This is when they present. Some of the children can present with unusual autoimmunity. So the tumor incites some autoimmunity in the child, and they present with opsoclonus myoclonus. This is again a very unique feature of neuroblastoma, and there's autoimmunity against the nerve cells. And in parallel to chemotherapy, we have to use immunotherapy. So we have to use steroids, we have to use IVIG, we have to use rituximab, control the autoimmunity, and that results in good overall survival. Imaging has come up in leaps and bounds. So from the time we had only bone scans and MIBG, so much has advanced with imaging in neuroblastoma, and we now have clear image-defined risk factors. If the tumor is encasing vessels, nerves, it's growing across compartments, invading porta hepatis, renal pedicle, and organ infiltration. Should I do a PET or MIBG? So this, for those who have access to both modalities. For all the stage 1, 2, and 3 neuroblastomas, PET is the best because it's available in all level 1, 2, 3 tier cities. MIBG, it takes time to order, and it has a unique position only in the stage 4 neuroblastoma children because it helps us detect bone or bone marrow metastasis. So we would do the PET, look at the assessment, and start the treatment, not wait for an appointment 2 weeks later, 3 weeks later for an MIBG scan. to start treatment, because the sooner we start treatment, the better. So PET has now got a key role in detecting all of the disease extent and bone marrow mets. So a PET can give us a lot of information. This is a new kid in the block, DOTATATE scan, which is specific for neural tumors. So you can see the pelvis on the right, and on a normal conventional scan, it looked okay. But on a DOTATATE scan, it's lighting up. So these are specific for neural tumor. And we use this because we have another type of therapy called lutetium therapy, and a DOTA scan, if it's positive, we could offer that in the place of MIBG. It is a less toxic version. Pathology makes a huge difference in neuroblastoma. So you have ganglioneuroma, ganglioneuroblastoma, and neuroblastoma. Ganglioneuroma is benign, neuroblastoma highly malignant. In this in-between group, ganglioneuroblastoma, if the pathologist gives the keyword intermix, these do well. But if they say it's not the intermixed, but then the prognosis is poor. So we have to treat them differently. Based on this, we have international classification by the pathologists. And why it matters to us in our treatment is if we have a ganglioneuroma or ganglioneuroblastoma intermix, then chemotherapy is not effective. We can do resection, and in these, even if we do a subtotal resection, it's enough. So we don't have to give them chemotherapy to shrink the tumor, because A, it's not going to work, and B, it's not needed. The next, we realize that genes matter. I think this is one of the main learning curves in neuroblastoma. All our cell cycle is controlled by the accelerator and the brake pedal. So proto-oncogenes tell the cells to divide, and tumor suppressor genes tell the cells to stop dividing. So there's a clear difference in neuroblastoma. So if you have the low and intermediate risk groups, they have whole chromosome gains. Whereas if they have the high risk, they have segmental aberration. So if you have whole chromosome gains in the tumor tissue, you know they belong to a good risk group, but segmental aberrations, they belong to the adverse risk group. So there's a very clear difference. So on day one, these 4 key genes in neuroblastoma are going to tell us is this good prognosis or bad prognosis? And we've learned more and more to respect the tissue that we get on day one to help risk stratify our patients. So we look at 17q. NMYC is the most important because it drives the neuroblastoma cells to divide. So it's one of the arrest differentiation protein, and if it's amplified, then it keeps on growing. So the impact of NMYC has come through several studies over time, and NMYC non-amplified do so much better than NMYC amplified. The impact of 7q status is also come through several studies, and if they have normal 17q, they do better than the gain of 17q. This is a new term in cancer, loss of heterozygosity. And LOH is a cause of several cancers. So when the cell divides, it has to give two chromosomes to each of its daughters. But if one of them gets 1 and the other gets 3, and both the defective genes are given to one daughter cell, and that is the one that's expressed, that is called loss of heterozygosity. So there is not one good and one bad, both are bad. So LOH. So LOH of one chromosome 1p is a key feature, and it carries poor prognosis. So genetics impacts on survival. So we need to have, and this correlates well with the histology. So the good histology differentiated ones don't show all of these poor genetic factors. So they all go hand in hand. So based on this, the Children's Oncology Group and St. Jude's have got a nice PCR-based assay. Say they look at the DNA on day one, a tumor sample, and say you have good signature, you have bad signature, you go into low and intermediate risk because you have good signature, and you go on to high risk because you have a bad signature. And based on that, they plan treatment. Because risk stratified therapy matters. You don't want to be giving chemotherapy to children with low risk localized tumor. So this is the basis of risk stratification. Next, we learn when to wait and watch. You have a small baby with neuroblastoma. If they don't have respiratory distress, a huge liver that's compromising their breathing, and they're not in DIC, we can wait and watch. This is the most difficult thing to do for a surgeon and pediatric oncologist, but all of the wait and watch pays off when the child grows out of the tumor. This is the key learning for me in neuroblastoma. We have novel approaches in surgery. So Dr. Radhakrishnan in our team has described a novel approach to cervicothoracic tumors. Dr. Shankar has done amazing work on the spinal tumors. And Dr. Neville Solomon's group has helped us with the thoracic tumors. And there's no one better with robotics than Dr. Sripathi. He used to get so excited before with the KUSA when he had the ultrasound guided resection. But now with the robotic assistance, the results are better and better. But the simple approach to surgery still matters, that if you have a low and intermediate risk, subtotal resection is good. We don't have to go and remove major vessels. But if it's high risk, we have to aim for complete resection. So even if it means involving a vascular surgeon doing major resection, it is useful in high risk. And we have location-based differences. For example, intraspinal tumors, we don't go after them. Only do what is outside of the spine. This is our part. Chemotherapy matters. And in low risk, there's no role for us. It's all in the surgeon's domain. Intermediate risk is the most gratifying of the neuroblastomas to treat, because the child has 4 cycles chemotherapy. We reassess, it's operable, they get operated. Then we have another 4 cycles of chemotherapy. And it's our job to deliver it in a safe manner. We need to give them venous access, because sometimes they are small children, give them supportive care and do age-adjusted chemotherapy administration and follow them up. However, the high-risk neuroblastoma chemotherapy has been quite a challenge over time. So many years since the treatments have started, the results have not been as great, only in the range of about 30% the outcome. So what do? We diagnose metastatic neuroblastoma. We give the induction chemotherapy, reassess. If we can operate at that time, go ahead and do the surgical removal. And then they come back to us for the high dose chemotherapy. The principle being, you have a chemosensitive tumor, you want to give very high doses of chemotherapy, which the bone marrow will not tolerate. So we take their hematopoietic stem cells, keep it in the freezer, give them the high dose chemotherapy in the form of busulfan, melphalan, and use the stem cells as rescue. And then they go for the 21 gray radiotherapy, and then a maintenance treatment in the form of cis retinoic acid. So this has been the long journey of stage 4 neuroblastoma. There are 2 groups. One is the Cyopen, which has the gentle induction, which is called rapid Kojek, whereas COG, which is heavy chemotherapy base. So in rapid Kojek, the timing matters, lower doses, but at rapid intervals every 10 days, whereas in COG, we give very high doses. So if you look at all these drugs, the cumulative doses are so high, and we're using doxorubicin in very young children, which is potentially cardiotoxic. So we have an added topotecan. So we have to be mindful of what we're using in these children. Autograft, the principle is to give the high dose chemotherapy to remove residual neuroblastoma and then use the stem cells as rescue. So collecting stem cells in very young infants can be a challenge. So we have our pediatric ICU, and we've done infants as young as 6 months collection of peripheral blood stem cells, and it's quite a challenge. Cryopreservation, because they need 1 week of chemotherapy. So freezing them to keep these stem cells alive until we finish the chemotherapy. And then we have to have 2 weeks of supportive care, which can be quite challenging, because some of them can't even swallow their saliva. When they vomit, there is hematemesis, there's intense mucositis and veno-occlusive disease of the liver due to busulfan. What about autograft in neuroblastoma? After having such a painful procedure, is it worth it? Autograft, yes, it does make a difference. The autograft survival compared to conventional just chemotherapy, there is a survival advantage in the high-risk children. And this is clearly seen if we add additional cis-retinoic acid. So if we have just chemotherapy, the survival on average is 18 to 20 months. Autograft gives disease-free survival for at least about 30 to 40% of the patients. What conditioning chemotherapy do we use? Busulfan and melphalan have now become the standard of care, and we don't use all the high-mech protocol that we were using before. All these treatments are expensive. So you have a metastatic disease with 30% survival. So the high income countries can afford this. What about the low and middle income countries? A lot of them go straight to palliative care from day one. So how can we help? And this is a unique paper from PGI Chandigarh. So all of the rapid Kojak is done as outpatients. Then they send them for surgery. Then they come back, have stem cell pheresis, and they don't store the stem cells in the freezer. So cryopreservation adds about 75,000 to the cost. They keep them in the fridge for 7 days, collect more than is required so that even if a few cells die, the others will be enough to bring back the blood hematopoietic system. They don't use central lines and use PEG GCSF on day 4, and they have found an equal 3 years event-free survival at 39%. So yes, we can do autograft and high-dose chemotherapy even in low and middle income countries, the achieving cure at low cost adaptation. What about MIBG in the high-risk neuroblastoma? It was useful, and they have scores called Curie scores and Sciorpan scoring at the time of diagnosis. So after the induction, if we repeat the MIBG and there is still residual disease, is it of any way useful? And NANT is a group which has new approaches to neuroblastoma treatment. And this is the protocol that they used, had the induction, and then did the surgery. And then before the autograft, use MIBG as therapy, big doses of MIBG, and then did the autograft. And with this, they found that the results were so much better compared to just the autograft. So you add in everything you can, because these are difficult diseases. Our part as transplanters, especially half-match or haploidentical transplant, interest came with the use of natural killer cells. These are the cells in our immune system that provide tumor surveillance. So natural killer cells are supposed to look at tumors and remove them. And when they're not able to see the tumors, that's when cancer occurs. So instead of using autograft, we thought adding an allogenic donor, a half-match father donor stem cells, will help us give the chemotherapy, but also provide natural killer cells, which will add the tumor surveillance. Unfortunately, you can see that the theory was good, but the 5 children we've done haploidentical transplant, the results were as disappointing as the autograft. So although in theory natural killer cells help, practically we didn't see a big difference with using an allogenic donor. Lateral thinking, instead of killing the cancer cells, can we help them gently grow from an immature form to a mature form? So these are called differentiating agents. And cis-retinoic acid, as you can see here, just a pulse cis-retinoic acid, from immature, they become mature neuronal cells. So cis-retinoic acid we use after we finish the transplant. We give them the local 21 gray radiotherapy to the tumor bed and 6 months of differentiating agent. And it's very well tolerated in children. And only thing we watch out for is hypercalcemia and skin exposure to the sun. So it offers a survival advantage. So now we've come to the modern era where targeted therapy matters. So we found that neuroblastoma cells carry a unique antigen called GD2. And we now have a specific antibody against GD2. So once the neuroblastoma cells are tagged to the GD2 antibody, the immune system wakes up. So our white blood cells, macrophages, natural killer cells all come in and try and remove and eradicate the neuroblastoma cells. So this is immunotherapy. And this dinutuximab has scored way over standard therapy. And the difference is between the 40% range to the 60% range. So it's giving a 20% survival advantage, which no other therapy has given so far. The only thing at the moment is for a 10 to 15 kg child in our country, the cost of 5 cycles of treatment is 1.75 crores. So it is beyond the reach of the common man. So hope is now renewed with neuroblastoma, even in the high-risk therapy, high-risk groups, where we can do induction with chemotherapy, consolidate them with either iodine, radioiodine, MIBG therapy or autograft, and then put them on maintenance, either with the dinutuximab or cis-retinoic acid. Radiotherapy matters. Sometimes the tumor bed is in the thorax, close to the heart. Tumor bed is near vital organs. So the radiation has to be focused. So intensity modulated radiotherapy, focused radiotherapy, so that the other organs are not affected. And this is where probably a proton radiotherapy can score over photon, because it focuses and stops at the tumor bed rather than spread and give radiotherapy to the surrounding tissues, so that the child doesn't have late side effects. Late effects matter. So this was a beautiful paper which in ASCO, where they said rethinking success beyond 5-year survival. So these are small children into whom we are pouring in radiotherapy, chemotherapy, surgery. What happens to them later? The sad thing is, these children with time are prone to a huge number of second malignant neoplasms. So they get so many cancers, and it increases and increases over time. So it's nearly 15% at 10 years. So that is why we need to look differently and not pour in so much of heavy dose treatment in the form of chemotherapy and radiotherapy. So this is what we see as the future in high-risk neuroblastoma. We have one Brahmastram. Why keep it for the relapse patients or the high-risk patients whose disease comes back? So the current trials internationally are to use our Brahmastram upfront, don't give chemotherapy. The induction is with anti-GD2 antibodies. Then you perform the surgery. Then they have the autograft, which is the only chemotherapy the child will have with busulfan and melphalan. Then they have the local bed radiotherapy, and then they are consolidated with another round of anti-GD2 antibody and cis-retinoic acid. So hopefully in the future, these are the children that are going to survive with intact survival, without organ damage, without organ dysfunction, with heart, kidney, all organs intact without the risk of second malignant neoplasm. Neuroblastoma, if anything, I think for all of us will teach us humility, especially when they are relapsed and refractory. We have to follow the protocol, and we shouldn't assume that the behavior of the disease is going to be the same. We have to be good at planning palliative care. Oral metronomic chemotherapy is very, very important in this group. We are now looking after a child who's 11 years old. He was diagnosed to have neuroblastoma when he was 4. He's had chemo, he's had surgery, he's had radiotherapy, he's had an autograft, and he's had about 2 MIBG therapies and 3 lutetium therapies. So he's very well. He's going to school. So the disease biology is different. So even though they have advanced disease, it doesn't mean they cannot be supported. And MIBG and lutetium therapy have a good place to support palliative care, and to give family time to accept the fact that the child's disease is progressing. MIBG is very difficult to deliver because the child has to be isolated for 5 days. The advantage of lutetium therapy is it can be done as a day case procedure, and all of the neuroblastoma cells go into temporary remission. There are new drugs also to offer new hope for such patients, because we now understand that the tumor carries a protein called ALK, and we have ALK inhibitor drug called crizotinib. It carries a neuronal tyrosine kinase inhibitor, and we have drugs to block the TRK receptor. So, in the words of Einstein, I think the important thing is to not stop questioning why, and we have better answers, and there will be hope for tomorrow. The one thing about neuroblastoma is that we have to have perfect counseling on day one, because the family needs to understand us well. We shouldn't give too much hope or hype or keep it too negative. This is difficult even for physicians. So what is the family circumstance, expectation? If they are only going to sell their only agricultural land for the autograph, is that something that we should be offering to the family? I think this does have an impact on the whole family. It's not a diagnosis for that one child, but the whole family. And the physician and nursing team, mental health as well, because as soon as you give chemo, a sick child gets dramatically better. They're running around, playing in the ward. And when they relapse, we are back to square one. So seeing this up and down has a heavy toll on us as well. So I'll end my talk with the 10 commandments that I had promised. The first one is that we should have very good risk stratification before surgery. We need the tumor biopsy. We have to have NMYC, and we have to have histopathology, at least basic NMYC before we operate. There's no need to hurry and operate on a child. Should I do MIBG or PET? We'll get PET for everyone. Add the MIBG in the high risk cases, but not to delay treatment to wait for a MIBG scan. Discuss these cases in a multidisciplinary team early, because there are people around us who can help and plan the perfect treatment for these difficult children. And surgery is always easy after chemotherapy. The good risk infants, we can safely wait and watch. Unless there are pressure symptoms, there's no need to operate on them. If they are low risk, intermediate risk, we can give near total resection. But in the high risk, we have to aim for complete resection, and the timing of surgery is crucial as soon as we finished induction chemotherapy. If there's some more left behind, no point going and saying, let me give 2 more cycles of chemo and then operate. So timing is crucial. In ganglioneuroma and intermixed ganglioneuroblastoma, there's a role only for surgeons. We don't have a part here. Whereas in the intermediate risk, if we give adequate chemotherapy, it makes the tumor very operable. But more than 4 cycles are not going to reduce the tumor size anymore. So better to proceed with the treatment. In high risk, these children need chemo, radiotherapy, surgery, the full work. So it's very important for the family to be counseled at every step to say every modality of treatment we have, we will be using. It's going to be long. The total treatment is for about 10 to 12 months. And they have to stay near the cancer center for a very long time and go through so many ups and downs. New targeted therapy is available even in India. So we as a pediatric oncology group are trying to work very hard to make sure that this unique treatment will come at an affordable cost for our patients. So we will work as a group to make sure that the access is there. Initially, the cost will be high, but hopefully the cost will reduce over time. And finally, good palliative care with oral metronomic chemotherapy, MIBG therapy, lutetium therapy, targeted therapy can help these children go through these painful bone mets and bone marrow mets and pressure symptoms, and for the family to see and cope with it much better. So there are things we can still offer. So we never say we can't do anything. There is always something we can do to support. The most important thing is that there's no role for surgery in palliation. So if the tumor has come back and it's high-risk neuroblastoma and they go back to the surgeon, there's no point in operating, because it's not going to help the child. So with neuroblastoma, what do we learn? We need to adapt to change. So மாறுவதை புரிந்து கொண்டால் மயக்கம் தெளிந்து விடும். So change is the only constant thing. So each child is risk adapted, and over time our knowledge of this disease has evolved, and we have to adapt to say at this present moment what is available and what can I offer for this family. I want to end by thanking each one of you for this patient listening, for the organizers of the Yusuf Memorial Lecture, the organizers of the conference, all of the patient families and the little children for their trust. I think of all the kids that we treat, the neuroblastoma children teach us a lot of things about resilience and how they can cope with difficult situations with a great smile. And the wonderful pediatric surgeons with whom we work, Dr. Sripathi, Dr. Bagde, who has been a guiding source for us right from the beginning, Dr. Radhakrishnan, Dr. Rajiv, Prakash Agarwal, Jimmy, and Balamurugan. Radiation oncology team has been a silent support so far because they have a small role to play in neuroblastoma, but they do play a very important role. Great physicians to work with, Dr. Ramya, Dr. Venkatesh, and Dr. Indra, a PICU consultant, with whom none of this work will be possible because very tiny kids, we've treated neuroblastoma right from newborn to 12-year-old. And for different age groups, we have to have different ways to adapt to each of these age groups. The nursing team, and a big thanks to Dr. Girish Chinnasamy from Tata, who has always been my go-to guy to ask about neuroblastoma and the latest what is available. And Indian Pediatric Oncology Group, Dr. Venkatesh is now doing a study on India-wide data on Autograft. Is this something we should be offering in our country, and what we can do better? Thank you so much for your patient listening.
Thank you, madam, for your nice presentation. Kindly wear the medallion.
Sure.
Kindly wear the medallion. We, the association, office bearers and members, thank Dr. Abul Hasan, one of our pediatric surgeon from my place, who has installed this oration. Thank you, Dr. Abul Hasan. Thank you.
Thank you very much, sir.
Thank you, sir, for the opportunity. I really appreciate it. Yeah.
Yeah. Can I say a few words, President?
Yes.
Yeah, indeed, I'm very happy that this oration is going on in our TPPS conference for years and years. Myself and my family all very much privileged to have this oration. And I'm also happy Dr. Revathi is also connected to me professionally. She has done some of the bone marrow transplantation in our patients. She may remember Shishant,
Yes.
child who underwent bone marrow transplantation by you, madam. Secondly, the subject, TPPS has chosen a very nice subject of very, very disturbing disease. So long, even in this advanced era of medical technology and treatment and delivery, neuroblastoma is one disease still challenging us. So you have dealt this subject very well, and we have got a very big duty to do for these unfortunate children, to make them more comfortable, or at least not cured completely. So let us make them comfortable. Let us utilize all these things available, whatever you have mentioned, these things, and the TPPS will be able to help these children. And also we have a trust back home here, like we helped this boy Santosh to undergo bone marrow transplantation. And through this trust, we will be definitely helping these neuroblastoma children also to undergo this costly kind of treatment to make them pain-free in their course of life. Thank you very much for delivering a wonderful lecture on my beloved father's name. And also thank TPPS organizing committee for having done this oration wonderfully well. Thank you, one and all.
Thank you.
Shall we
Thank
move
you.
on to the next session, Dr.